Question 1. Mrs. Wilson is a 63-year-old woman admitted to the ICU with acute myocardial infarction. Her initial electrocardiogram shows some segment elevation in leads VVV. She has a history of hypertension, hyperlipidemia, and type 2 diabetes. After receiving thrombolytic therapy, her blood pressure dropped significantly and she developed symptoms of cardiogenic shock, including hypotension, tachycardia, and low urine output. What is the most appropriate intervention for managing Mrs. Wilson's cardiogenic shock? A. Administer norepinephrine to improve vasoconstriction. B. Perform an immediate coronary artery bypass graft (CAMG) surgery. C. Increase the infusion rate of normal saline to treat hypovolemia. D. Discontinue the thrombolytic therapy and monitor closely. Answer A. Administer norepinephrine to improve vasoconstriction. Explanation: cardiogenic shock is caused by the heart's inability to pump enough blood to meet the body's needs, often resulting from acute MI. In this case, norepinephrine, a vasopressor, is the best choice to increase systemic vascular assistance and improve perfusion to vital organs. This helps stabilize the blood pressure in patients experiencing shock, while CAB may be considered later, not the immediate treatment for shock in this setting. Increased fluid infusion would not be effective in this case, as the issue is not hypovolemia, but the heart's inability to pump blood effectively. Thrombolytics should not be discontinued without further assessment, as they may still be necessary to resolve the clot. Question 2. A 70-year-old male patient with a history of chronic obstructive pulmonary disease, COPD, and congestive heart failure, CHF, is admitted to the ICU with acute respiratory failure. The patient's ABAB results reveal pH of 7.32, POCO of 55 mHg, and POW of 58 mHg. The healthcare team is considering whether to initiate invasive mechanical ventilation (IMV) or non-ventilation (NIV). Which of the following criteria would indicate that the patient should be managed with invasive mechanical ventilation? A. The patient is alert and able to cooperate with NIV. B. The patient has worsening hypoxemia despite NIV and is unable to protect his airway. C. The patient exhibits signs of respiratory distress but is maintaining normal blood pressure. D. The patient's pH is within normal limits and there is no significant POCO increase. Answer: B. The patient has worsening hypoxemia despite NIV and is unable to protect his airway. Explanation: invasive mechanical ventilation (IMV) is indicated for patients who do not respond to non-invasive ventilation (NIV) or for those unable to protect their airway. This includes cases of worsening hypoxemia, as in this case where the POW is critically low, 58 mHg, despite NIV. NIV is generally used for patients with COPD exacerbations or mild respiratory failure, but if NIV fails to correct the hypoxemia or if the patient becomes unable to protect his airway, IMV is the next step. The other options do not meet the threshold for IMV initiation, as the patient's alertness and ability to cooperate with NIV suggest that non-invasive options should be exhausted first. Question 3 scenario. Mr. Roberts, a 45-year-old male, was admitted to the ICU following a severe car accident resulting in multiple fractures, blunt trauma to the abdomen, and significant blood loss. On admission, his Glasgow Coma Scale (GCS) is 13, his blood pressure is 90, 60 mHg, heart rate is 120 bpm, and respiratory rate is 28 breaths per minute. He is receiving fluid resuscitation with normal saline and his oxygen saturation is 95%. The trauma team is discussing the next steps in managing his condition. Which of the following should the ICU team prioritize for Roberts? A. Immediate surgical intervention to control internal bleeding. B. Monitor Mr. Roberts' GCS score every hour to assess neurological function. C. Initiate high-flow oxygen therapy to maintain oxygen saturation above 98%. D. Administer vasopressors to elevate blood pressure and improve perfusion. Answer: D. Administer vasopressors to elevate blood pressure and improve perfusion. Explanation: Mr. Roberts is showing signs of hypovolemic shock due to blood loss. While oxygen therapy is important, maintaining his blood pressure and perfusion is the priority. Vasopressors such as norepinephrine or dopamine would be used to support his blood pressure in this critical phase. Fluid resuscitation with normal saline is a key initial step, but vasopressors required if he remains hypotensive despite fluid management. Immediate surgery may be necessary for controlling internal bleeding, but it is not the first step for managing shock in this situation. Monitoring the GCS is important, but the immediate priority is to stabilize his circulation. High-flow oxygen is beneficial but not the primary intervention for shock management. Question 4. A 58-year-old male patient is admitted to the ICU with a diagnosis of cardiogenic shock following an extensive anterior wall myocardial infarction. He is intubated and mechanically ventilated with an arterial line and a pulmonary artery catheter in place. His hemodynamic parameters are as follows: heart rate 118 EPM, blood pressure 85/50 Hg, pulmonary capillary wedge with 24 Hg, cardiac index 1.8 L minimum, systemic vascular resistance SER 2300 dynosecum. Which of the following interventions would be the most appropriate first-line treatment to improve this patient's hemodynamics? A. Administer rapid fluid bolus of 500 ml normal saline. B. Start norepinephrine at 0.5 mg and titrate as needed. C. Initiate dobutamine 8 mg to improve cardiac output. D. Increase ventilator tidal volume to enhance oxygenation. Answer: C. Initiate dobutamine at 5 mg to improve cardiac output. Explanation: the patient's hemodynamic profile indicates cardiogenic shock characterized by low cardiac output psi 1.8 Lmin and higher with 24 Hg, reflecting left ventricular failure. The best initial treatment is dobutamine, adrenergic agonist that increases myocardial contractility and cardiac output with significantly increasing SER. A. Incorrect. Fluid resuscitation is not recommended in cardiogenic shock due to the IW, which suggests left ventricular overload. Excess fluids could worsen pulmonary edema. B. Incorrect. Norepinephrine is primarily vasopressor that increases SVR. While useful in septic shock, it can worsen afterload in cardiogenic shock. D. Incorrect. Increasing tidal volume does not address the underlying issue of low cardiac output. Relevant guidelines: American College of Cardiology (AC) and American Heart Association (AHA) recommend inotropes dobutamine milrinone for patients with cardiogenic shock to improve cardiac output before considering vasopressors. Question 5. Scenario-based. Mr. Alejandro, a 45-year-old construction worker, was admitted to the ICU after sustaining 40% total body surface area TBSA burns in a workplace accident. On arrival, his vital signs are HR 132B, E 95, 60 ml 30 breathmin, urine output THR. The provider orders fluid resuscitation using the Parkland formula. What is the most appropriate initial intervention to ensure adequate resuscitation? A. Administer 4 mg% of lactated ringers over 24 hours with half given in the first 8 hours. B. Start norepinephrine infusion to maintain blood pressure. C. Give rapid bolus of 1L normal saline and reassess urine output. D. Initiate total parenteral nutrition (TPN) to prevent metabolic complications. Answer: A. Administer 4 mg% of lactated ringers over 24 hours with half given in the first 8 hours. Explanation: burn patients require aggressive fluid resuscitation to prevent hypovolemic shock. The Parkland formula 4 ml/kg is percent per burn is the gold standard for initial fluid management, with half of the total volume administered in the first 8 hours. B. Incorrect. Norepinephrine should not be as first-line treatment in burn shock. Hypovolemia due to capillary leakage is best managed with fluid resuscitation. C. Incorrect. Single bolus may temporarily improve hemodynamics but does not provide adequate ongoing resuscitation. D. Incorrect. Nutritional support is crucial in burn care but does not replace fluid resuscitation in the acute phase. Relevant guidelines: American Burn Association about guidelines recommend the part formula for burns 20% EBSA to prevent hypovolemic shock. Question 6. The patient in the ICU with acute respiratory distress syndrome is on volume controlled ventilation. The settings are tidal volume 8 mg, respiratory rate 16 breathmin, PEEP 5 cm Her, FiO 80%, arterial blood gas BAB results, pH 7.30, PaO 55 mg, PaO 6 mg. What is the best adjustment to improve oxygenation in this patient? A. Increase tidal volume to 12 mg to improve ventilation. B. Increase PEEP to 10 cm Hg to improve alveolar recruitment. C. Reduce respiratory rate to 12 breathmin to decrease hypercapnia. D. Increase FiO to 100% to maximize oxygen delivery. Answer: B. Increase PEEP to 10 cm Hg to improve alveolar recruitment. Explanation: ARDS patients benefit from lung protective ventilation, which includes low tidal volumes (CAG) and high PEEP to prevent alveolar collapse. Increasing PEEP improves oxygenation by enhancing alveolar recruitment. A. Incorrect. High tidal volumes 8 mag increase the risk of ventilator-induced lung injury. C. Incorrect. Reducing respiratory rate would worsen hypercapnia and acidosis. D. Incorrect. High FeO increases oxygen toxicity risk. PEEP is preferred to improve oxygenation. Relevant guidelines. ARTSNP protocol recommends low tidal volumes (CAG) and high PEEP for ARDS patients. Question 7. A critically ill patient is receiving continuous renal replacement therapy for acute kidney injury (ICI). The nurse notices that the patient's serum calcium levels are decreasing. What is the most likely cause? A. Increased citrate use in RRT circuit leading to chelation of calcium. B. Hyperkalemia causing calcium to shift intracellularly. C. Hypophosphatemia leading to increased calcium excretion. D. Excess fluid removal causing dilution or hypocalcemia. Answer. A. Increased citrate use in RRT circuit leading to chelation of calcium. Explanation. Citrate is used as an anticoagulant in RRT and binds to calcium, forming a complex that is removed in the dialysate. This can result in hypocalcemia, which requires calcium replacement to maintain normal levels. B. Incorrect. Hyperkalemia does not directly lead to hypocalcemia. C. Incorrect. Hypophosphatemia affects APRODA, but does not cause significant calcium loss. D. Incorrect. Fluid shifts may dilute electrolytes, but are not the primary cause of hypocalcemia. Not or relevant guidelines. Kidney disease improving global outcomes. KDIGO guidelines recommend calcium monitoring in patients who are with citrate anticoagulation. Question 8. A 72-year-old male with a history of heart failure with reduced ejection fraction (HFrEF) is admitted with worsening dyspnea, orthopnea, and lower extremity edema. His vitals: CHA 92 EE, 135 AMH, 24 Breathman. O saturation 92% on room air. BNP 1250 EGML. Which of the following is the best initial treatment? A. Steromen furosemide and monitor urine output. B. Administer Roman-UID to improve preload. C. Initiate Milrinone infusion to increase cardiac output. D. Perform urgent dialysis to remove excess fluid. Answer. A. Roman furosemide and monitor urine output. Explanation. This patient is experiencing acute decompensated heart failure (HFrEF) with volume overload indicated by dyspnea, orthopnea, and edema. The first-line treatment are diuretics, furosemide, to reduce preload and improve symptoms. B. Incorrect. Fluids worsen congestion and heart failure. C. Incorrect. Milrinone is used for cardiogenic shock. Initial management of volume overload. D. Incorrect. Dialysis is reserved for severe cases with renal failure or refractory congestion. Relevant guidelines. AHOC heart failure guidelines recommend diuretics as the first-line therapy for acute volume overload in HFrEF. Question 9. A 54-year-old male with a history of chronic atrial fibrillation and hypertension is admitted after a syncopal episode. His ECG shows sinus bradycardia with frequent pauses up to 6 seconds. Which intervention is most appropriate? A. Start metoprolol to control heart rate. B. Prepare for permanent pacemaker implantation. C. Perform synchronized cardioversion. D. Initiate Roman heparin O to prevent embolic stroke. Answer. B. Prepare for permanent pacemaker implantation. Explanation. This patient has symptomatic bradycardia with sinus pauses, suggestive of sick sinus syndrome, which often requires pacemaker for definitive management. A. Incorrect. Beta blockers metoprolol further slow heart rate worsening symptoms. C. Incorrect. Cardioversion is used for tachyarrhythmias, not bradycardia. D. Incorrect. Anticoagulation, heparin, is important for stroke prevention but does not address the underlying bradycardia. Relevant guidelines. American College of Cardiology (AC) guidelines recommend pacemaker for symptomatic sinus node dysfunction with significant pauses. Question 10. A patient with septic shock is receiving epinephrine but remains hypotensive. Lactate levels are 4.2 ml and central venous oxygen saturation (SCVO) is 65%. What is the best next step? A. Administer Roman-UIDs and reassess hemodynamics. B. Add vasopressin to improve vascular tone. C. Start dobutamine to improve cardiac output. D. Switch norepinephrine to dopamine. Answer. B. Add vasopressin to improve vascular tone. Explanation. This patient has refractory septic shock where norepinephrine alone is not sufficient. Vasopressin is a second-line vasopressor that enhances vascular tone and reduces norepinephrine requirements. A. Incorrect. Fluid resuscitation may help early in sepsis, but excessive fluids can worsen capillary leak syndrome. C. Incorrect. Dobutamine is used for low cardiac output states, but this patient's SCVO is still adequate. D. Incorrect. Dopamine is inferior to norepinephrine in septic shock and has more side effects. Relevant guidelines. Surviving Sepsis Campaign recommends adding vasopressin if norepinephrine alone is insufficient to maintain 60 pharmacy. Question 11. A 66-year-old patient with cirrhosis is admitted to the ICU with acute varicose bleeding. After securing the airway, what is the most appropriate initial therapy? A. Romidazole PPI to reduce gastric acid, or romanotriaide to reduce splanchnic blood flow. C. Emergent esophageal stenting. D. Tauromin albumin and aggressive crystalloid resuscitation. Answer. Romanotriaide to reduce splanchnic blood flow. Explanation. Acute varicose bleeding in cirrhosis is best treated with romanotriaide, a somatostatin analog that decreases portal hypertension by reducing splanchnic vasodilation. A. Incorrect. PPIs are used for peptic ulcers, not varicose bleeding. C. Incorrect. Endoscopic band ligation is preferred over stenting. D. Incorrect. Albumin is helpful but does not directly stop bleeding. Relevant guidelines. American Association for the Study of Liver Diseases also recommends octreotide and early endoscopy for varicose bleeding. Question 12, scenario-based. A 33-year-old trauma patient arrives in the ICU with a severe traumatic brain injury TBI. His ICU is 24 Hg. What is the best intervention to lower ICU? A. Give mannitol or hypertonic saline. B. Increase PEEP to improve oxygenation. C. Start high-dose corticosteroids. D. Hyperventilate the patient to PAO 25 Mhg. Answer. A. Give mannitol or hypertonic saline. Explanation. For elevated ICU 20 Mhg, the best approach is osmotic therapy, mannitol or 3% saline to reduce brain swelling. B. Incorrect. High PEEP can increase ICU by impairing venous drainage. C. Incorrect. Steroids worsen outcomes in TBI patients. D. Incorrect. Hyperventilation is a last resort. POCO 30Hg can cause ischemia. Relevant guidelines. Brain Trauma Foundation BTF recommends mannitol hypertonic saline for ICU control. Question 13. A patient on mechanical ventilation suddenly develops hypotension and high peak airway pressures. What is the most likely cause? A. Tension pneumothorax. B. Pulmonary embolism. C. Myocardial infarction. D. Acute pulmonary edema. Answer. A. Tension pneumothorax. Explanation. Sudden hypotension and high airway pressures suggest tension pneumothorax, which occurs due to barotrauma in ventilated patients. B. Incorrect. Pulmonary embolism causes hypoxia, but not increased airway pressures. C. Incorrect. My causes hypotension, but not airway resistance. D. Incorrect. Pulmonary edema presents with crackles, but does not cause high pressures. Treatment. Immediate decompression followed by chest tube placement. Question 14. A 58-year-old female with a history of hypertension and diabetes presents with acute chest pain and dyspnea. Her shows depressions in leads EVV and troponin levels that are elevated. EP is 110/70 Hg and HR is 88 BPM. What is the most appropriate next step? A. Tyromine nitroglycerin and monitor blood pressure. B. Perform immediate percutaneous coronary intervention ECI. C. Give a bolus of romanoids and recheck blood pressure. D. Administer alteplase TP. Answer. B. Perform immediate percutaneous coronary intervention ECI. Explanation. This patient has NSTEMI with posterior ischemia, depressions in VVV requiring urgent coronary angiography, and PCI. A. Incorrect. Nitroglycerin can help symptoms, but PCI is the definitive treatment. C. Incorrect. Fluids are not indicated unless the patient is hypotensive. D. Incorrect. EPA is only for STEMI when PCI is unavailable. Guidelines. AHOC recommends early PCI for high-risk NSTEMI patients. Question 15. A 67-year-old male with COPD is intubated for respiratory failure. His ABAG shows EH 7.20, POCO XMHG, POW 84 Mhg, 28 Meckel. Which ventilator setting should be adjusted first? A. Increase respiratory rate. B. Increase FEO. C. Increase PEEP. D. Decrease tidal volume. Answer. A. Increase respiratory rate. Explanation. This patient has respiratory acidosis, high POCO and low pH, so increasing the respiratory rate will improve ventilation and low POCO. B. Incorrect. PHEO affects oxygenation, not ventilation. C. Incorrect. PEEP improves oxygenation, not co-clearance. D. Incorrect. Decreasing tidal volume worsens co-retention. Guidelines. ARDSNP protocol suggests R adjustments optimize co-clearance. Question 16. A 45-year-old trauma patient is hypertensive with a positive fast exam fluid in Morrison's pouch. What is the most appropriate next step? A. Administer 12 normal saline and reassess. B. Perform an urgent laparotomy. C. Obtain CT scan of the abdomen. D. Tauromin and ropinephrine. Answer B. Perform an urgent laparotomy. Explanation. A positive fast exam indicates intra-abdominal hemorrhage requiring immediate surgery. A. Incorrect. Large fluid boluses can worsen bleeding. C. Incorrect. CT delays definitive treatment. D. Incorrect. Pressors are not first line for hemorrhagic shock. Guidelines. Advanced trauma life support methods prioritizes surgical control of bleeding. Question 17. A 70-year-old post-op patient develops acute confusion, tachycardia, HR 120, and hypertension, BP 8555. His skin is warm. Labs are B 18,000 mm. Lactate 5.0 ml. Creatinine 2.1 dl. What is the best initial intervention? A. Tauromin and broad-spectrum antibiotics. B. Govroman hydrocortisone for adrenal insufficiency. C. Initiate dopamine to support blood pressure. D. Obtain blood cultures and delay treatment until results return. Answer A. Tauromin and broad-spectrum antibiotics. Explanation. This patient has septic shock requiring early fluids and antibiotics. B. Incorrect. Steroids are only for refractory shock. C. Incorrect. Fluids should be given before pressors. D. Incorrect. Delaying antibiotics worsens mortality. Guidelines. Surviving sepsis campaign recommends fluids plus antibiotics within 1 hour. Question 18. A patient with aortic dissection presents with severe chest pain radiating to the back. BP is 109 to 100 mHg. What is the most appropriate next step? A. Romanate. A. Betalol to lower blood pressure. B. Steroids to support perfusion. C. Perform thrombolysis with alteplase. D. Initiate heparin for anticoagulation. Answer A. Govroman ibetalol to low blood pressure. Explanation. Hypertension worsens dissection, so beta blockers, labetalol, should be given immediately. B. Incorrect. Fluids increase shear stress on the aorta. C. Incorrect. Thrombolysis can cause rupture. D. Incorrect. Anticoagulation is contraindicated. Guidelines. AHA recommends beta blockers for BP control in dissection. Question 19. A mechanically ventilated patient suddenly becomes hypoxic with a tracheal shift to the left. What is the most likely cause? A. Tension pneumothorax. B. Aspiration pneumonia. C. Pulmonary embolism. D. Acute respiratory distress syndrome ARDS. Answer A. Tension pneumothorax. Explanation. Tracheal deviation plus hypoxia suggests tension pneumothorax, which is an emergency. Treatment. Immediate needle decompression followed by chest tube placement. Question 20. A 60-year-old with acute pancreatitis develops hypoxia and diffuse pulmonary infiltrates. What is the best intervention? A. Start lung protective ventilation. B. Give high-dose Romani steroids. C. Perform urgent bronchoscopy. D. Start broad-spectrum antibiotics. Answer A. Start lung protective ventilation. Explanation. This patient likely has ARDS requiring low tidal volume ventilation. B. Incorrect. Steroids do not improve ARDS outcomes. C. Incorrect. Bronchoscopy is not first line. D. Incorrect. Antibiotics are only for infection-related ARDS. Question 21. A post-op patient suddenly develops SOB tachycardia, HR 120, and pleuristic chest pain. What is the most likely cause? A. Pulmonary embolism. B. Myocardial infarction. C. Pneumothorax. D. Aortic dissection. Answer A. Pulmonary embolism. Explanation. Post-op patients are at high risk for presenting with acute dyspnea and tachycardia. Diagnostic test. CT pulmonary angiography. Question 22. A 45-year-old with a bleedus tachycardic, HR 120, and hypotensive EP 8550. What is the most appropriate fluid choice? A. 2 units PAC RBCS, Roman albumin. C. 1 normal saline. D. Dextrose 5% in water. Answer A. 2 units PAC RBCS. Explanation. Patients with hemorrhagic shock need blood transfusion, not just fluids. Question 23. A 72-year-old patient with a history of chronic kidney disease (CAD) and heart failure presents with progressive dyspnea and bilateral pulmonary crackles. His EP is 198 av Show 92 em and SPO 88% on room air. Chest X-ray shows bilateral pulmonary edema. Which of the following is the most appropriate initial management? A. Administer furosemide. B. Tyromina normal. Saline at 125 AHR. C. Perform urgent dialysis. D. Give Romani, nitroglycerin, and morphine. Answer A. Administer furosemide. Explanation: this patient has acute decompensated heart failure with pulmonary edema. The first-line treatment Romani-Retix furosemide to reduce fluid overload. B. Incorrect. Give Roman-Uids worsens fluid overload. C. Incorrect. Dialysis is only required if diuretics fail or if severe hypokalemia occurs. D. Incorrect. Nitroglycerin can help reduce afterload. Diuretics are first line. Guidelines: AHOC heart failure guidelines recommend loop diuretics as first-line treatment for pulmonary congestion. Question 24. A 54-year-old patient is in the ICU with severe septic shock. Despite receiving 4 Roman-Uids, his OP remains 80 if DMH show 120 pm and lactate is 4.5 ml. What is the best next step? A. Start norepinephrine infusion. B. Give an additional Roman-Uids. C. Administer romanadrocortisone. D. Start dopamine infusion. Answer A. Start norepinephrine infusion. Explanation: this patient has septic shock unresponsive to fluids, requiring a vasopressor, norepinephrine, to maintain perfusion pressure. B. Incorrect. Excess fluids can lead to fluid overload. C. Incorrect. Steroids are only for refractory shock. D. Incorrect. Dopamine is not first line due to arrhythmia risk. Guidelines: surviving sepsis campaign recommends norepinephrine as the first line vasopressor. Question 25. A 30-year-old trauma patient is brought to the ED after a motor vehicle collision. He is confused hypotensive EP 75/58G and has a distended abdomen. Fast exam reveals free fluid in the peritoneal cavity. What is the most appropriate next step? A. Immediate laparotomy. B. Obtain an abdominal CT scan. C. Start norepinephrine or BP support. D. Administer Roman-Uids and reassess. Answer A. Immediate laparotomy. Explanation: this patient has hemorrhagic shock from blunt abdominal trauma requiring emergency surgery. B. Incorrect. CT scan delays life-saving intervention. C. Incorrect. Vasopressors do not replace surgical bleeding control. D. Incorrect. Fluids alone will not correct active bleeding. Guidelines: ATL's guidelines prioritize surgical control of bleeding in unstable trauma patients. Question 26. A 68-year-old with atrial fibrillation presents with acute left arm weakness and facial droop. Last seen normal 2 hours ago. BP is 145/88 mAt. V-head is negative for hemorrhage. What is the best treatment? A. Administer Roman-Uids TPA. B. Start aspirin and monitor. C. Give Roman a heparin infusion. D. Perform urgent mechanical thrombectomy. Answer A. Administer Roman-Uids TPA. Explanation: this patient has acute ischemic stroke eyes within 3-hour window and meets criteria for OPA. B. Incorrect. Aspirin is used if EPA is contraindicated. C. Incorrect. Heparin is not first line for acute stroke. D. Incorrect. Thrombectomy is only for large vessel occlusions beyond the TPA window. Guidelines: a Hasa stroke. Guidelines recommend OPA with 4.5 hours of symptom onset. Question 27. A 50-year-old with liver cirrhosis presents with altered mental status and asterixis. His ammonia level is 100 TWEC in DDL. What is the most appropriate treatment? A. Lactulose. A furosemide. A romanoiamine. D. Hemodialysis. Answer A. Lactulose. Explanation: this patient has hepatic encephalopathy and lactulose lowers ammonia by increasing excretion in the stool. B. Incorrect. Diuretics are for ascites, not encephalopathy. C. Incorrect. Thiamine treats Wernicke's encephalopathy, not hepatic encephalopathy. D. Incorrect. Dialysis is not needed for ammonia clearance. Guidelines: guidelines recommend lactulose as first-line therapy. Question 20. A 45-year-old post-op patient suddenly becomes hypotensive EP 85/50 tachycardic HR 120 and develops cold extremities, essential venous pressure CEP is 3AG. What is the most likely diagnosis? A. Hypovolemic shock. B. Cardiogenic shock. C. Septic shock. D. Obstructive shock. Answer A. Hypovolemic shock. Explanation: This patient has OCVP plus hypotension plus tachycardia, suggesting hypovolemia due to post-op bleeding or fluid loss. B. Incorrect. Cardiogenic shock has elevated CVP plus pulmonary congestion. C. Incorrect. Septic shock has warm extremities initially. D. Incorrect. Obstructive shock would have distended neck veins. Guidelines. Athels recommends aggressive fluid resuscitate. Hypovolemic shock. Question 29. A 55-year-old presents with acute confusion, dry mucous membranes, and polyuria. Labs show 168 meckel serum osmolarity, 330 mols urine osmolarity, 100 mols. What is the most likely diagnosis? A. Central diabetes insipidus. B. Syndrome of inappropriate. A. Secretion SIAD. C. Hyperosmolar hypoglycemic state. HSD. Adrenal insufficiency. Answer A. Central diabetes insipidus. Explanation. This patient has hyponatremia plus dilute urine, which is consistent with diabetes insipidus. D. B. Incorrect. SIDE causes hyponatremia. C. Incorrect. HS has severe hypoglycemia 600 mdl. D. Incorrect. Adrenal insufficiency causes hyponatremia. Guidelines. Endocrine Society recommends desmopressin DDEF for Central D. Question 30. A mechanically ventilated patient develops sudden oxygen desaturation and high peak inspiratory pressures. What is the most likely cause? A. Pneumothorax. B. Pulmonary embolism. C. Pleural effusion. D. Myocardial infarction. Answer A. Pneumothorax. Explanation. Ventilator patients are at high risk for barotrauma, leading to tension pneumothorax, which increases airway pressures. Management. Needle decompression and chest tube placement.